So hello, I would say that we can start our third session. It's going to be the continuous of the previous one. It's going to focus on a cluster of opinions, focusing especially on measuring performance of health systems. My name is Sabina Nuti. I'm a member of the expert panel, and I am a professor of health management in Sant'Anna University in Pisa. I will give the floor to my colleague Dion Gringos that will present a brief presentation regarding this cluster of opinions focusing on measuring performance of health system. And afterwards, like in the previous session, we will give the floor to the different perspectives, so to the stakeholders, to the member states representative, and then at the end to Sylvain Giraud as representative of the European Commission. So please, Dion, if you would like to start your presentation.
Thank you, Sabina. It's a great pleasure to be here, and I'd like to welcome you back. I do realize I have two challenges to hopefully overcome. One, it's after lunch, so you have far too relaxing chairs, I realize. So I realize you want to sit back, so hopefully I'll be entertaining enough for you to relax after lunch. And secondly, a lot has been said already. And I will try not to be too repetitive, because some of the challenges we experience are related to very much the topic that we tackle, and some are more related to the work that we do. So bear with me, and perhaps some of the repetition is not that bad. So I am Dion Gringos. I realize not all of you will be familiar with me before today, and I think that's a good thing. It tells you that it is not the usual suspects or the usual experts. I know where there are suspects, but it's not the usual people who always take part in these type of panels. So I think that's a good thing. It's also selfish to think that, but okay. I am the youngest one of the panel, so I think that's also a good thing. It tells you we are multi-generational. I am a woman. I am fully aware of that. So, and given the gender balance, more than 1/3 of the members are women. So I think we pay attention to the gender balance, but I do hope I'm here for my expertise foremost. We are multidisciplinary, and perhaps some would say transdisciplinary, but I myself was also trained multidisciplinary, and it tells you perhaps also how we train our professionals nowadays. I was trained in health economics, policy, law, and also health services research, and I hope that it's brought benefit to our work. And lastly, I am also multicultural. I mean, my blood is Dutch, Greek, and I'm influenced also by my Portuguese family. So it does tell you something. We are not representing our countries. I make, work, and live, and have been brought up in the Netherlands, but we are here to represent a certain expertise and put it to good use. At least that's what we aim to do so. But it's up to you to say if we are doing a good job. And it's a challenging job. And I just want to give you a sense of the flavor. What are the type of challenges that we have experienced working in the area of measuring performance of health systems? So I can tell you what we aim to achieve, and I'll ask you later on if you think we are working in a good way to achieve those. It has been said we work on developing frameworks because it gives logic to our thinking. It's always an oversimplification of the complexity of the world, but it's a good starting point, and it helps our thinking, and it also gives us boundaries. We all need boundaries in order to be effective and efficient. And once we have settled a kind of reality, or our version of the reality of the world, we can then work on the concepts. Our work is not so much technical. I think it's more on the conceptual level, and that's important when we discuss the wicked issues of very important but wicked policy issues. And it also helps us in order to speak the same language. And that may sometimes be obvious that we use the same words, but we mean totally different things. It's not intentional, sometimes it is, but it's also around translation issues. I'm not a native English speaker, but I do hope you understand me. But I may use words that are more Dutch English, so it's in our nature also. But when we work on complicated problems, it's important to be transparent about what we mean with the things. And we our purpose of the work is, but also the starting point of our work, is to have a shared understanding of what is the real policy question. And sometimes we end our mandates also by asking new questions. But I do think whenever we were confronted, let's say, or proposed a new mandate, we always start with, what do you mean? What is the real question that you are asking us as a panel? And sometimes we went into, well, often we had a debate also directly with the European Commission, and at times that led to a rephrasing of the policy question. It was not that they were not asking us to work on the wrong things, but it's the way you ask a question and whether we feel capable enough to answer it. So I just want to make the point that there has always been a clear dialogue. It's not like we are assigned to work on something and we just obey to the assignment. That's not how we work, and that's also the great thing of being an independent panel. So the opinions that I would like to cover, which is reflecting of the broad area of the measurement of health system performance, relate to disruptive innovations in healthcare, relates to how to evaluate whole health policy reforms. I see that the wrong cover was used. It says access, but actually it was innovation. It had to do with assessing the important area of primary care performance, how to assess the impact of digital transformation, what is value in value-based healthcare, a very popular term nowadays, and how to bring the work of task shifting forward. What is task shifting and when is it appropriate or not? So that's the broad area that we have been working on in the area of measurement of performance. And we have, oh, well, let me go back one more. We've always been aware that it's not up to policymakers to read 100 pages of reports. And we do always have the intention at the start of the work to be short this time. Let's aim for a report of 30 or 60 pages. But it is a complicated area, and it helps our own thinking also to use at the beginning more words. And then at the second stage, we are able to make a fact sheet out of it. So we are aware of our own limitations, sometimes related to being an academic, but it's also related to the complexity of the topic. In our titles of our opinions, you may have noticed or not, we have become shorter. So in getting the right message across, sometimes it's also the importance of having a clear front page and a short title. We have managed to become shorter. So we do work on fact sheets, and we are fully aware that it doesn't end with a fact sheet. Some of here in the audience are representing stakeholders, and you have also become more and more active to invite us to come to your own important events and to be discussing the topics that we've been working on. We have been invited by the European Parliament also. So there has been a lot of outreaching from our side, but also from the European Commission to get the message across. So we're fully aware that it doesn't end with just delivering a piece of paper, even though we're very proud of the pieces of paper. So if you read across our opinion, it's good to realize that they're all based on a number of values and guiding principles also that we think is very important in our work. And we try to be truthful to those. And sometimes that's complicated. But one of those is the awareness that equal achievement of health is an essential investment for all health systems and government. And especially the equal achievement, so the distributional aspect, is very much related also to the solidarity principle that we highly value. We also always underline the importance of universal health care and that we strongly believe in the importance of having together, creating and stimulating a social cohesive European society, and that having a strong health system is really contributing to that. When we talk about solidarity, I mean, it's a big issue, and we have tried to operationalize that when we talk about the key functions of health system. For instance, when we touch upon access and equity, it's about social justice and having fairness across all. When we talk about quality of care and performance of health system, it is related to delivering responsive care, appropriate care and safe care, and also very much person-centered care, being truthful to what the patient really has in mind in terms of the importance of its own life, and what are the patient goals. And when it relates to value and efficiency and productivity, all very much often economic concepts, even though we argued in our opinion they are not just economic concepts. It's also about optimization and distribution of resources. And the fifth, and perhaps, well, I wouldn't say most important, but very underlining all of our opinions, we always try to stimulate the role of the European Union in stimulating and creating learning communities, in really be open-minded in learning across countries, also from less well-resourced countries and health system to higher income and learning communities, because we truly believe in international exchanges of best practices and also things that don't work. So it's all about the learning. So these are basically the key principles that are all throughout our opinions. Now, it's very difficult to be with so many people around the table, representing so many views and our own biases from what we know, to have a coherent opinion. And we do try to have a well-balanced, coherent opinion by balancing our expertise. Expertise not just in the group of members of the panel, but we always, whenever we feel limited by our own expertise, where we think we need to be broader, we involve external experts. And that can be in a structural role, where we really take up an expert in our own dedicated working group working on an opinion, but it can also be just consulting with experts in the field, and some of you were those. As said before, we deliver a draft opinion and then we have public hearings. And I've seen many of you actively participating. We're very happy with that. So you're also responsible in part that our opinions are coherent and well balanced. And then we always reflect, we take each of your inputs always seriously and reflect whether or not that means that we need to change certain things of our opinion. Well, our mandates, they do cover some similar areas, but they all have their own emphasis. Some emphasize, like Martin also said, more on the definition of concepts. And that always starts with having that shared opinion of policy questions and having the right word. This morning, we spoke a lot about contextualization. I also want to argue the opposite. In order to be able, at an international level, at a very aggregated level, to be able to talk about policy issues and policy options to tackle those, at first you need to decontextualize, to have a real conversation. What are the policy issues at hand? What are the real struggles? And then along the way, you need to then zoom in again and see what is the impact, what are the enabling and hampering factors, or you could also say the context-dependent factors that will influence the implementation or the policy options at hand. So in our work, we had to first zoom out and then zoom in again. And somewhere in between, we make our recommendations that are as practical as possible for different contexts. But yeah, to some extent, it's also up to the countries themselves to see, okay, how can we make this fit in our own particular context? And we always try to integrate different perspectives. And that means the personal perspective of the patient. It's not just a patient, that's also a person, a human being having a certain role, a family role, and so it's in the full context. We look at the institutional perspectives, also the health organization perspectives, and we always try to also go beyond the health system. We realize that everything we do in healthcare has implications for society at large. So we always try to take a broader societal perspective and be transparent about that, or do our best effort to see what the potential impact is. Now, for instance, in the area of value-based healthcare, here I show you the type of mandates that we are confronted with. Our mandate was pretty much focused on definition. So how do you define value in value-based healthcare? What are the aspects of health systems that could a different definition cover? And how could value-based healthcare actually contribute to health system transformation? So we were pretty much confronted with coming up with a clear definition of value. So how do we approach that? Well, we took, I think overall we took 5 steps. We first analyzed the current situation. And we looked at ongoing initiatives to increase value. And we always also take a historical perspective, look at how have other people worked in the area of value-based healthcare in the past. And then we do an appraisal of the established instruments and methods, and we identify what are the key values out there. And then we propose some key principles for implementation and recommendations. So it's a broad approach to perhaps a seemingly simple question, but it's certainly not. And that results in our sense, a very important, in our opinion, a very important new definition of value, in which we try to appreciate the personal value, we appreciate the technical value, the allocative value, and also the societal value. And we've seen in looking historically on the discourse on value-based healthcare, it's often about the economic perspective and what value is. And we really proposed a more comprehensive definition where we said, well, actually, value-based healthcare is a comprehensive concept that's built on 4 value pillars. It's appropriate care to achieve each patient's personal goals as a human being, achievement of best possible outcomes with available resources, equitable resource distribution across all patient groups, and contribution of healthcare to social participation and connectedness, so societal value. So we always see healthcare and individuals also in the relation of being part of a connective society that's contributing to our health. Now, what are the issues when we are more focused on the measurement? So once we know what the clear concepts are and what are the key features to measure, so what are we struggling with if we really need to measure? Well, here the historical perspective is always important before we start, actually, and to see what are the key concepts we need to measure. We then try to identify who are the most important potential users of the measure. So who wants to know? For what purpose do they want to know? And then the question is, of course, can we service all of these potential users in our opinion? That's another aspect. But we try to struggle with the fit for purpose for the measures. And we have always struggled with the restrictions of existing health information infrastructures. So if you want to summarize the struggles that are out there in the measurement area, you could say well, there are the struggles in which indicators to select. There are the struggles with the current data information infrastructures. Thinking about measurement, do we want to limit ourselves to what we can measure at the moment, or do we want to stimulate the things we think we need to measure but are not able yet? And then choosing the proper analysis method. And one of the topics that was displayed or relayed this morning was also, and then how to display actually the messages. And that's something we haven't really tackled in our opinion, but we are fully aware that it doesn't end with doing the right analysis. It's then how to wrap the messages, and that's also with our own messages, so how to package the messages, and then how to make it actionable so that the stakeholder that needs to use the information can actually act upon it and has the mandate to act upon it. So in sum, that's the reality of when we talk about measurement, and these are the struggles that we were also confronted with, and sometimes we were just transparent where the difficulties are without being able to solve them at this moment. So more concretely, one of our opinions were on how to measure, how can countries assess primary care performance. And one of the challenges that we were aware of was that many indicators that are currently being used are not really specific for primary health care. So that we're often not able to really measure the impact that primary care is responsible for. And one of the solutions to work around that is to focus on the ambulatory care sensitive conditions. And you see that also in the international comparative work that the OECD, for instance, is doing. So that's one of these solutions. We also see that if you want to compare outcomes of primary care, it does require contextualization to give proper inference to the findings. And we, particularly in this opinion, we really put focus on recommending that we need more attention to the patient, or I would even say now the individual's personal goals in life, and that's not always clinical. It's not always harmonious with the clinical perspective on what's important for the patient at this moment in time. And talking about the current health information infrastructure, we are always aware that some health system aspects, like how providers are being paid, thinking about, for instance, pay-for-performance systems, are actually influencing how we are measuring certain things, how we are registering our data. And then no matter what the topic is, if we talk about developing frameworks and measures and indicators, there's always a struggle in. Ideally, you want as few indicators as possible in order to be powerful also and to use something. And but you don't want to lose too much. You don't want to oversimplify things. So there's a struggle between the breadth and the depth that you can tackle in using indicators. And then talking about contextualization, well, we in some of the opinions, the emphasis was more about the impact of enabling and hampering factors. And there the struggle is, on the one hand, you want to consider things in a broad and changing dynamic environment, and you want to address policy issues in a generic matter, but on the other hand, you want to be also future-proof. So you also want to develop an opinion that's robust enough for the coming years also. So, for instance, when we talked about task shifting, we identified a number of factors that influence the change towards task shifting, such as changing patterns of the disease, advancements in technology. More things are possible. So we're seeing shifts among providers of care. We see shifts from providers of care to patients, but we also see shifts from humans to machines. And another driver towards task shifting was the shortage of health workers that almost all countries are suffering from. And cost containment is sometimes also used as an argument towards task shifting, and definitely also decentralization of organizational structures. So these were some of the contextual issues that we identified that are influencing this discourse and also the possibilities of it. Now, when we were assigned but measuring impact of digitalization, for instance, then we start often with the impact on the health system and health system goals, but we also try to look broader at societal impact. And we do sometimes also cover fiscal sustainability and the economy at large. I mean, a healthy person is also a productive person, so it's also good for economy. And we also sometimes looked at the legal impact. So, for instance, on our opinion on digitalization, and the question of the mandate was, what impacts do we need to measure systematically when we touch upon digitalization? One of the things we said was, not everything needs to be measured, but what certainly needs to be measured is the intended and unintended outcomes in relation to the health system objectives. And we underlined that it's really important there to take the societal perspective, and also the distribution of aspects, so equity and all. Now, lastly, we're often asked, because we are working as an independent panel for the European Union, so we do try to stimulate the EU towards a certain agenda, but I think and I hope we went even beyond that by also simulating the creation of learning communities, giving suggestions to member states, and also making recommendations for our own work as scientific communities. So I'd like to end with giving you a number of messages. I mean, you also gave a message to us that we need to have a clear narrative. Well, I just want to give away four of our opinions that we were proud of. In relation to primary care, in our opinion, the identified characteristics and criteria for the development of primary care performance assessments can provide a starting point for strengthening the coherence across assessment frameworks for countries and exchanging best practices. So we hope that we have been contributing to that. In our opinion, value-based healthcare now has a comprehensive new definition where we can move the discourse away from just a narrating perspective on health outcomes and value-based pricing towards a more inclusive, personal, technical, and allocative and societal value. In our opinion, digital transformation will be measured by the health system objectives achieved, and not just by the use of technology in itself. The technology is really a means towards health. It should not be the focus of our evaluation in itself. And task shifting has a lot of potential. It has the potential to contribute to health system strengthening when it is really accompanied by adequate planning, resources, education, training, and transparency about the impacts also of all stakeholders involved. So those are some of the opinions that we are proud of, and we hope that we're contributing to also your work. Thank you.
Thank you. Thank you, Dion. Thank you very much. And now we give the floor to the panel. I think you allowed us to have a lot of suggestions and to be discussed by the panel. And I will start considering the perspective of the member states, and I will give the floor to Professor Silvio Busaferro, President of the Italian National Institute of Health.
Good afternoon. Thank you very much for inviting me to this expert conference and for giving me the opportunity to share with you some ideas. What I try to do in the 5 minutes I have for the next 5 minutes is I try to find out some keywords. I have 4 of them. The first one is real world. I think that is part of, you can find traits of real world in the expert opinion, still published, but I think also is a challenge we have in the future. Real world meaning has many meanings. I tried to go through some of them. They are not exhaustive, of course. The first one is we have to consider that health is an issue, but well-being is another one. And we have to mix up indicators for looking to well-being. people in our countries are expecting well-being too, to be measured. The part of the trust in the system is the ability of the system to create well-being. That means that it's not really just healthcare, but society. The other one is about data and indicators. We have a lot of them. There are lists and lists of indicators. It's not Martin McKee just mentioned that we have loads of indicators and then they are dishomogeneously collected. The denominators, let's say, are not common and we are not exhaustive both in almost all our countries. But I would focus on a special issue that you can find out also in the existing database at European Union level. It is the way we represent our situation. You can find out in the database of Euro data that you can find. If you represent our European Union, you have some data, you have a picture in the world, then you go to nations and you have another picture, then you go to regions. If you look at Europe, European Union, through the region lens, you find out another Europe. With much more commonalities than we can suspect among countries. If you look at the number of beds for hospital, birth rates, poverty, GDP, other kind of thing, you can find really another Europe very coherent in the same area. So the same area has the same problem all around Europe. And I think this is a challenge if we want to change or to improve quality of healthcare and quality of our lives. Of course, the further level is communities. I don't want to go through too much on that, but communities are the other challenge. The other one is real world means we have to think to new way of doing epidemiology. Real data are available. There are loads of data. They are becoming available. The issue of big data, we have no time to go into, but is a very, very challenge. And this real-world data have two great critical areas at the moment. The first one is the time gap, let's say. By the time we are able to set up a surveillance, the real world is more steps ahead. So people with the watches, with the tools, are measuring a lot of things. And the time we need to set up a surveillance system is much more slower. Plus, we have a lot of rights to be saved in protection of data that in many countries, of course, for certain in Italy, make very, very difficult to share data, even if they are anonymized. So it's a critical point we have to face too. And the challenge is, I had the opportunity to participate last week to the World Assembly of the World Agency on Drug Regulation. And if you look at some example of the way they plan to manage drugs and to control the effect of drugs, you find that I was really impressed by a picture proposed by a colleague from the United States, FDA, and they call it a behaviogram. And you have a map, a sort of clinical chart of the day, where all the data for your watch, for your iPhone, for your iPad, for your everything you measure, you have in a single picture, whatever you do in one day. That meaning you have real data as a feedback. And these kind of tools tell you immediately what to do, what they recommend, which is recommended for your next hour, to complete your 8,000 steps by day. Let's say it's an example, but they do that. They are real world. They are just experimental clinical trial in this way. So the way we design, or we have been trained as epidemiologists, is of course a very strong evidence-based situation, but the challenge at the horizon is further, is how do we manage we guarantee evidence of the impact of what we do with real data. A further issue before going to the second word is communication. We are speaking about omics, so everything is personalized. We are producing loads of data for single enzymes, genetics, whatever you want. People will be overloaded with data about that. They are all percentage of risk, or risk expressed, not meaning exactly you are going to be healed or not. But the other thing is the way we communicate to these people is very traditional, because we assume that, as we assume before the personalized care, that the people is within a Gauss cure. So it's a mass. It's not true. We have a dividing by generation. I have some example. I have the slide in my iPhone, but the problem is that every 10 years, generation change the way they communicate, change the values, and it's not just one generation, it's 10 years. So we have to be very effective and personalized also in the way we communicate overall with young generation that, as someone mentioned in the morning, are part of our priority investment. I'm convinced about that. The second word, so real world was the first one. The second one is integration. Integration means that we have to consider all the system all together. The first one is now we are able to estimate risk long life. Is dementia is one, other kind of chronic diseases can be predicted or can be analyzed. And we have to integrate a long life approach. It's not anymore relevant, even for financing single approaches, single intervention. The second one is we have to put together data in a world in larger agenda. Sustainable Development Goals have been mentioned, of course, is one of them. The other approach is One Health approach that we have to consider not just for antimicrobial resistance or for everything we do. But the integration means overall for health, integration with social services, frail people that are a growing part of our society. The older we become, the luckier we are, but the more need of integration of social care is needed. If we don't do that, no system, no insurance of universal coverage system can be affordable economically. And this means integration, we have to consider also the future that is forecast by the Society 5.0 that has been discussed in the last G20 in Japan. And if you look at the 5.0 society, you look that all data are collected, they are managed, and you get them in your iPhone, in your watch, and telling you what to do, guiding you what to do. This is a challenge you have to face, and it's not really a long time future, it's tomorrow. The third word is trust. I think that this decade has been a key words in our system, is value. And you just mentioned your report. The next decade, probably trust is one of, I suspect, can be one of the key words. Because trust meaning that trust between patient and healthcare workers, between society and system, between journalists and professional, between communities, between trust in artificial intelligence. It has been, JAMA has published just last summer a very nice series of papers discussing of this issue. I think this is a part of the thing we have to do. And I remember when the first paper in New England appeared about value, was a very big discussion at the beginning of these decades. And then we are just, now value is something we have metabolized, let's say. Or we are working, not all of us, but anyway, it's a very common topic. No one is discussing about the centrality of that. But trust is not. And part also of hesitancy is part of trust. And we have to face this kind of issue. Yes, the last word, are implementation and complexity. Even with the current system, with the current epidemiology, with the evidence-based system, we have a lot of evidence. As a system, as policymaker, but we have also very single thing, like hand washing, like antimicrobial prescription, very simple thing that apparently seems simple, but technically is practically, we are not able to face them, because the percentages of implementation are very poor. We are successful in some countries, of course, but in the most of our countries still is a big, big challenge. So meaning that how do we implement the evidence we have is a challenge. We have not too much evidence. We have some evidence, of course. We have good practices, of course, but we have not such a strong evidence. And part of the problem could be also the way we imagine our organization, that is very linear. And I think we have to even include, make us more comfortable, more expert in complexity science. We are a complex adaptive system, healthcare system, society are complex adaptive system, and there are some rules we have to follow. We are not aware about that. I think this is a part of opportunity we have in the future. Thank you very much.
Thank you, Professor Brusaferro. I give the floor now to Enrique Barros, the President of the Portuguese National Health Council, for his
I can just use it. Okay, thank you very much. Thank you. Good afternoon. Thank you very much for the opportunity and for allowing me to share with you all these very interesting documents and discussion. I think I can begin with a quotation from Lord Kelvin. He wrote that to measure is to know. If you cannot measure, you cannot improve it. So I think it's quite central, this approach to measuring performance of health systems. But I would also like to stress the one thing that has been present during the morning and now this afternoon, the importance of clear definitions, clear concepts, and clear terms. And most often when we think about measuring the performance of the health system, we are thinking about measuring the performance of healthcare, which is not exactly the same thing. And it's interesting how we fall in that, maybe because of the pressure of people suffering acutely or having diseases that change their life in a very clear way, and they expect things to change. But this sort of unclear approach to things that leave out most of the what we, in theory at least, tend to value, that is health promotion and prevention, lead us to use, and we used it already today very, very often, the concept of patient-centered care and patient-centered responses in the health system. And I think it would be nice if we could, at least in the documents where we have more time, because when we are speaking, the words just invade us in a way, and take something like, I don't know, citizen-centered or person-centered, if you want to go back to traditional psychological approaches of some decades ago. Because it would also take us away of this idea of consumer-centered, which is obviously an ideological approach to things, because it means that health is a commodity, and it makes this tension between that is often present when we say that health is a human right. Because if health is a human right, the way we measure the performance of the health system need to look for different indicators, or at least need to value special aspects that are not often considered. And also a real challenge that we face both in research, in academia, in the field work, in the practice, is the way we look at things. I mean, most of us, I was trained to see things on a sort of a multi-level way, like an onion with their layers, but we need to see things as systems. We need to remember that systems biology is around for a long time, and we need probably to bring those concepts and the way to see how things are related in the same or in a similar way. So that when we change something, we can have an idea how all the system is going to change. And it would open maybe a new door, because with less effort, we could change a lot of things at the same time. And you could even try to forecast what's gonna happen. Because now changes in the health system, and those are very difficult to measure, are often really media mediated. As Professor Brusaferro already said, we are now swimming in a sea of data, and you have this idea that big data is going to solve lots of things. Maybe yes, maybe not as many as people thought. Remember what was the idea that we could know everything about influenza epidemics just by looking to the traffic in Google, and then it's not like that. So we need to be more cautious about it. But what we see and what we face is that media is really shaping the way people is thinking. Of course, it always did probably, but now it's promoting situations that shouldn't be like that. I can give an example, a very recent example from my country, and it has to do also with what has been discussed here as the task shifting, or when discussing task shifting. Recently there was a scandal because of a doctor that has lots of problems with the quality of the ultrasounds he was doing to their pregnant patients. And so every TV, every written newspaper is discussing this problem, and the response of our medical association was to say, okay, we need to have a sort of a list of people with special skills for doing ultrasounds during pregnancy. And I would imagine that ultrasounds during pregnancy should be done by more and more and more people. Probably midwives should have much more, much larger participation in that. But the response to the scandal was to put it even more medically complex, and instead of designing or trying to negotiate a sort of a kind of a referral system that would work better and so on, because errors are human. As you know, it's the IOM title for a long time. Okay, yeah, perfect. So what I would like to stress also, and thinking about one, additionally thinking about one of the points and the topics that we were faced with in this session, that bringing together the question of disruptive creation and is thinking as the example and the values. I was thinking about the example of hepatitis C. You know, it's in the document, it's presented as a case study, but you know, now the countries cannot say how much they are paying for the medication. So how can we measure the performance if we miss one crucial data? Of course, the governments know and they can do it, but then we have to go to the other element of this system. It's the citizen and it's transparency. So people can also has the right to make to think about it. So finally, I would think that we face a real challenge that maybe is not as present as we need it, and it might be interesting for the future. Is that we need to think about mobility of people, global issues, and emergencies, and the emergence of different diseases. And regarding the impact, just to finish that, we also discussed does this panel, the panel work has an impact? I mean, it has, as we have seen. It will have much more. And I was just thinking about the work of Lind in the 18th century, when he discovered the role of lemons and oranges in scurvy. It took 50 years to put the lemons and the oranges in the navy for the sailors. So, I mean, nothing new under the sky.
Thank you very much, Professor Barros. And I leave the floor now to Douglas Gregory, Chair of the Working Group on Healthcare Systems, European Federation of Pharmaceutical Industries and Associations. Thank you.
Thank you very much. And let me just start off by saying two quick thank yous. One, first and foremost, to the European Commission and DG Sante, because somebody, I don't know who it was, but somebody a number of years ago took a decision to create the panels that enabled the panel to do the work that it's done and to produce the reports that it's done. And I think that's really, really important. Somebody took a risk to do that, and whoever they are, they should be thanked for that, for taking that decision. Secondly, I wanted to thank the panel in particular because you've done an immense amount of work with modest resources nonetheless, but modest resources. I note in speaking with a couple of your colleagues that actually you ended up writing a number of the reports as well, and that's no easy task at all. So congratulations for that. You wouldn't be surprised that as FPA, perhaps we don't agree with you on every single thing. And actually, you probably would be worried if I could say that we did. So I think that's great. But I want to talk to you a little bit about the work that we do at FPA on this. My background is not in the pharma industry. I joined the pharma industry 7 years ago. I spent 23 years at IBM, 3 years at Telephonic, and before that, I was a finance official in the Canadian government. You can probably tell my accent that I am an immigrant to Europe. I am now a Belgian citizen, a very happy Belgian citizen, but I'm originally from Canada. But when I joined FPA, I remember we went to the former Director General and said, as a systems person, I'm looking at this and I see a wonderful expertise in medicines, but it's a silo of medicines. And medicines only exist within a healthcare system which exists within a healthy society. And if we only understand medicines, that we are doing ourselves a disservice and we're doing European society a disservice. So the discussion said, no, Doug, I don't think we have enough expertise to do with that. And we're not going to start one. And obviously, we have one now, and we've persisted and we've demonstrated that it's important for our industry to broaden its perspective and to understand more than just medicines. And I think that's an important element of what we do. Our healthcare systems are predicated on a break-and-fix model. And I think we all recognize that that's not fit for purpose and certainly not fit for the future. And that's really where I think when I look at the work that the panel has done, and particularly the work on value and some of the ones on healthcare system performance assessment, you're really helping us and helping Europe articulate a way forward as to how do we move to that. And it struck me once, somebody said, you measure what you care about. And when we look at that, many of the things that we do measure on our healthcare systems are very monetized and are about money. And that means that our healthcare systems in many ways are predicated on financials. And our healthcare systems need to be much better than that. If we look at the challenge that we face about integration between healthcare, social care, and community care, you can't monetize all of these things, and you can't look at it strictly from a financial perspective. Money is important. There's no question about that. And the working group that I lead, we look at some of those big, soft European governance models. So we heard about the European semester before. We look after that. We look at the state of health that DG Sante puts out, the social pillar. We represent our industry at the OECD on the healthcare quality and outcomes working group, but also the Paris working group. And as colleagues know, there's also an aging report that our finance ministers look at in the context of the challenges of sustainability of the financing of our social model in Europe. All of those are really critical things that I think we look at. But the thing that strikes me the most is that if we do measure what we care about, then we should be looking at how do we measure things that are more relevant to patients and that patients care about. Because we have healthcare systems because we want to be able to make sure that we can return people to health. And how we measure that, I think, is really important. A colleague from our Finnish colleague who was up here was talking about the challenges that we face at national level about making the business case, the investment case for more money in healthcare. We have difficulty in creating a return on investment case, and we need to be better at that. And what better to do that than to focus our efforts around making sure that our healthcare systems are people and patient-centric, because in the end, that's why we pay the taxes that we do. That's why we invest the money in our healthcare and our social systems to go forward. So let me wrap it up there. I think there are a couple of things that perhaps may be recommendations for the next panel as it goes forward. I think one of the things that you could do would be to have an agenda of what you want to look at proactively. We had a good discussion today about questions and how do you define a question. I think for us, when we looked at some of the mandates that you had, we have a particular perspective, but the way we would have framed the question and the way we understood the question was very different than the way you answered the question. And if there could be some way of proactively communicating that, not just to the private sector, but to civil society, to other actors, NGOs, et cetera, so that everybody understands a little bit better about how does the panel look at this issue and how is it going to try to answer that? I think that would be very helpful and might assist in the uptake on that. And then I think in a number of the papers, I think there's an opportunity also to point more clearly the way forward for some people. So those are a couple of thoughts from us, but thank you again for the opportunity to participate.
Thank you very much. Then let's go to Frick Spinnelwin. Did I spell it well? That's correct. Almost. President of the European Public Health Alliance. Thank you.
Yes, thank you. Thank you for the invitation. I'm president of the Public Health Alliance, but that's a volunteer job. My real job, my paid job is director of FEANSA, which is an organization working on homelessness. One of these groups that actually is missed by evidence generally, so maybe an interesting focus for the future. First of all, congratulations to the panel for the work they did. I went through the effort to read the opinions for this session, and I thoroughly enjoyed it. Maybe just to make you to make sure that you understand that an organization like IFA, one of the major actors at European level on public health, is convinced of the importance of evidence. For several reasons. First of all, because it makes our lobbying more effective. We get more impact by basing our lobbying on evidence than we get impact by referring to who we are and our constituents. That's the first thing. Also because it makes our transnational work more interesting. Our members are interested in knowledge and expertise. Rather than just empty networking and exchanges. And thirdly, because we also want to be a progressive voice and want to change the practices and the way of doing that our members are involved in. And for that, you need evidence. If not, you don't have the authority to do that. So IFA is not a corporate voice of part of the public health sector. We try to be a progressive voice in the public sector, and for that, evidence is absolutely essential. Also, the evidence provided by the panel. Now, very quickly, a few comments on the work of the panel and maybe some suggestions for future focus. I thoroughly enjoyed reading the one on disruptive innovation. It was not mentioned in the early presentation. I don't know why that is, but I liked that. I thought it was one of the better ones. My reflection reading that was that you can only do disruptive innovation if you have atypical evidence builders or unusual suspects involved. If not, you can create the illusion of disruption. And I'm quite new to the public health sector, but I see a lot of the illusion of disruptions. People think they're disrupting, but they're actually not disrupting. And it often starts with an idea, one finding. And one of the most striking findings that I have read over the last couple of months was one that was in the World Health Europe report on the health equity gap, where they found that if you compare a number of really important state interventions that might reduce the health equity gap, they found that investing 1% more in housing is twice as effective than investing 1% more in health to reduce the health equity gap. That's an interesting finding, but imagine all the consequences that that brings. Like, that's an interesting topic, I think, for the new panel. I understand the focus on frameworks and concepts. That's really important for transnational comparison, coherence, but it sometimes tends to be an obsession for academics and researchers. If you are in the practice, you also need practical tools. You're opportunistic in the way you read these reports, and I think you have to find that balance. But I don't want to dismiss the importance of the definitions and the frameworks. In terms of follow-up, many of the opinions, many people have already said about how to follow up and the importance of knowledge brokering and stuff like that. Just another perspective on that. The Commission and the panel are very closely working together. It's difficult to get the member states to follow up, but it should be easy to get the Commission to follow up. And some of the recommendations are addressed directly to the European Commission. It was mentioned before, the need for learning platforms, for instance, is mentioned in several opinions, but that can be done at European level, but it's not always taken forward. In terms of focus, I'm getting to the end. In terms of focus, thematic focus, I think, and maybe it sounds totally superficial, but if that is, I'm very sorry, but I think you should focus on areas where the evidence is contradictory. There's quite a few areas where the evidence is not, at least from our perspective, clear, or where the evidence is lacking. Contradictory in the area of climate, for instance, air quality, etc. Because if the evidence is not clear or cohesive, unidimensional, it leads to inertia. And I think the lack of progress on climate is to do with that, to some extent. Evidence that is lacking, that's an area that I'm concerned about, but if you work with vulnerable, very vulnerable groups in health, there is very, very little evidence there. Evidence on social determinants, how they work, on health interventions for these groups, which are generally very ineffective, so the evidence can actually have quite a bit of impact. Last thing I want to say is on the composition of the panel. I like academics, we work a lot with academics, but I think academics and researchers cannot claim the monopoly on evidence anymore. That time is over. But at the same time, NGOs cannot claim the possession of the truth anymore. I think both we can work together, and maybe there is ways to integrate that in a bit more, that cooperation in a bit more structural way in the composition of the panel. And the very last thing I want to say is, I heard people saying, yeah, evidence doesn't work anymore, people don't believe us, and I think that's really a challenge. It's true to some extent. But if you talk about people that are, or in the area of public health, I wonder if we don't have to make a difference between preventions and people that are actually sick. If you're really sick, I think you're quite happy to embrace the evidence. But in prevention area, it's more difficult because it impacts on your life and you don't see the immediate need to do that. And maybe it's also because the evidence in some areas of prevention is not sufficiently established yet. I think there is a room for more work, but that's work that goes a little bit beyond the health sector proper. Thank you.
Thank you very much. So now the last comments are from Sylvain Giraud, head of the Unit of Performance of National Health System, DG Santé, European Commission. Please, Sylvain.
Yes, thank you, Sabina. Good afternoon. Yes, with my colleagues, we are lucky enough to be those that are responsible for supporting the panel in their work, and also for channeling to them the questions that they get, and to also, once their opinion are made available, to also contribute to the dissemination across the Commission and in different levels and fora. So let me start with an anecdote, because I've been fortunately or unfortunately, I've been around these things for quite a while. And in 2010, 2011, I was a much younger official, and I remember being in a meeting where Commissioner Dalli, who was then Commissioner for Health, and was talking about establishing this panel. And I remember one of the things he said we should be asking the panel, and that would be very useful, would be to know what is the optimal number of beds, of hospital beds per inhabitants. And when I've heard this morning, you know, all this what we heard about context and everything, is just like, I guess even that type of measurement probably is contextual, and as some people have said, it might not be the bed that's important, but what's around the bed, or maybe what's in the bed. Anyway, so this was the kind of things that originally there was this idea from politicians or the commissioner that there could be this kind of advice that you need, that there would be that magical number that everyone would agree with, and that would be the basis for the proper policy making. I think we all know that this was always been, still is, wishful thinking. So what we've been willing to do, as André also explained this morning, is to contribute to generate this advice, to generate evidence, to generate knowledge that could inform what we do as the Commission, but also the national policy making, and also that could contribute to shaping or feeding into debates at different levels, national level, EU level, with stakeholders, with everyone that has an interest. So it is true that it's probably for these reasons that a lot of the questions we've asked, the mandates we've sent, were around clarifying concepts, developing framework, and developing shared understanding, addressing some complexity, clarifying some buzzwords, and so on. Because this is where we felt that we had a mandate, that we had a role to play. Because as the Ms. Voipio-Poulkous this morning, I would not naturally turn to the European Commission for some of these things. That wouldn't be my natural resource. So I think, given the way we are organizing the European Union around health issues, we've focused on that. We focused on ways to contribute to the debate, ways to inform rather than design policies. And we never asked the panel to give us recommendations, because probably if we'd asked the panel to tell us, well, I heard that the panel has actually asked the Commission to do very specific things, and indeed there are some very specific requests, but otherwise we haven't asked the panel give us a list of the policy actions, because very often we're not the policy makers. We would not be able to implement it, and we would have a limited. What we can do is to provide the support for member states to learn from each other and possibly develop a common approach when that makes sense and when they think it makes sense. So that's how it works with the panel. They have been extremely good at developing a collective and consensual view on the issues we've asked them to consider. The word or the issue, the word multidisciplinarity, interdisciplinarity, transdisciplinarity, you've heard already many times today, and this is particularly relevant in the way they have worked. And again, they don't necessarily reflect the views of the Commission, but again, they have really helped us to build some of the analysis that we've done. In fact, if you remember, in 2015, when Jean-Claude Juncker and his Commission started, Mr. Andriukaitis received a mandate from Jean-Claude Juncker in his mission letter, where he was asked to develop cross-country and country-specific knowledge of health systems. And we believe that what the panel has been doing, it had actually started before this mission letter, but what the panel has been doing has been core to this mission that the Commissioner had to develop under the recommendation of the Commission's President. And we believe the panel has been an instrument also for us, for the Commission services, in the way we have analyzed health systems through the semester, you've already heard, in the way that we have looked at the health systems in the member states, their effectiveness, their accessibility, their sustainability, and what the concepts the panel has brought, some of the opinions that they have been looking at. These have helped us to build our own, the structure of our own analysis, and to also contribute across the Commission to issues like designing the EU funds, deciding the health intervention that EU funds could have. And this also, the way they've been looking at health systems reform, the way they've been defining, typologizing, describing health systems transformation, this has given us a structure again to develop a policy inside the Commission. So, what are the questions and how do we come with these questions? Well, we're trying to be quite collective in the way we work inside the Commission. So we've had a lot of consultations with our colleagues in DG Santé, but also across the Commission to come up with questions. And we want to continue to do that as much as possible. And so that also we want to articulate even more what we asked the panel with other work streams at EU level or important developments that we know member states are looking for. So, having said all this, I'd like to just go through some of the opinions that are part of this particular session now to tell you exactly how we believe they are actually articulated with other EU work. So in 2016, there was this opinion on disruptive innovation and also another one on the typology of health policy reforms. And those have really contributed to define concepts and structure for the analysis of country-specific cross-country transformation. I mentioned that for the semester. I could also say for the way we've built, this was mentioned already, we've built the state of health in the EU process and the way that together with our partners, the European Observatory on Health Systems and the OECD, we have developed the country profiles that are reports on the situation of health systems and public health in each of the member states, coming out every 2 days and every 2 years, sorry, and in a few days the 2019 series will be coming out. This is on the 28th of November. The opinion on methodologies for assessing the performance of primary care in 1917 was very important for the work that the member states in a group that we called Health Systems Performance Assessment, which is quite a technical group, but it's done quite a lot of work, maybe not visible enough, but where experts from the various member states have been looking at not so much as how to assess the performance of health systems from the EU level, but how they develop their own respective system in their own national environment and how they can learn from each other. The panel report on primary care, which is focusing on measurement and on assessing, was a very important basis for their own report and the way that they have developed the national instruments for measuring primary care, and it did also access that was discussed in the previous session. And the strengthening of primary care, which this report also highlighted with some ways to measure that, it was also a very strong message that we've tried to pass across the semester when recommending a certain policy direction for the member states' health systems reforms. The opinion on assessing the impact of digital transformation. Here again, we were about the assessing impact, measuring. This was also quite well received by the member states in the e-health group, where this group was particularly interested to develop their knowledge on how to process and define their investment needs and how to anchor their investment needs to a broader transformation of the health systems. There was also an opinion on defining value. We felt at the time when we had the panel for discussion that this was a very good subject where we needed clarification given the broad use of this concept, even if there were very already strong references in the literature and in the also policy debate about what it was. We felt that at least in the Brussels environment, the way it was used was sometimes not appropriate or at least confusing. And we hoped and we were very satisfied that the panel would bring some light in the way that this can be used in that context. And the most recent opinion that was in this morning's session on the role of health systems to support health promotion and prevention will also be an important base for the work of the steering group on prevention and promotion that I think John Ryan said that this morning. The last thing I'd like to say is that, and I mentioned that very soon, in a few weeks, we're going to publish the State of Health in the EU package. As I said, there will be country profiles, but as 2 years ago, there will also be a Commission document in this package, which we call the companion report, because it accompanies the country profiles. And in this Commission report, we're looking at 5 big transformation across countries for health systems. And the 5 that we are going to look at in a few days, or that you will see in the document that we will publish in a few days, they're very strongly related to some of the panel work and what the Commission is going to be suggesting, or it's not really suggesting. I think it's more analyzing on the basis of the situation in the member states' analysis, are very strongly related to the work of the panels. The first one is about the first chapter in that document is about tackling the decline in vaccination confidence. So something that was the subject of an opinion last year. Second trend is harnessing the digital transformation of health promotion and disease prevention. So here we're combining 2 important subjects, this idea of reinforcing prevention, but also the importance of using digital transformation for that purpose. The third chapter will be on access, and on how can we improve the way we measure access to healthcare to ensure that, and that this is what Martin was saying this morning, we ensure that we work towards a universal health coverage and a better measurement of how we progress to that. The fourth chapter is on task shifting between professionals and how this and skill mix development, and how this is a fundamental way to provide and prepare the workforce for the health systems of the future. And the last of the chapters is on affordability of medicine. So it's looking at how to break silos between different authorities and different parts of government at national level, but also maybe EU level, and cooperate more towards this subject. So I didn't need to mention that for each of these chapters, you have an opinion of the panel that have been one of the resources that we've used, obviously, for developing our work. So that's where I stop. Thank you very much.
Thank you, Sylvain. So now I would like to collect some questions or suggestions. If somebody would like to do a question, or yes, could you get and present yourself, please?
Hi, Boris Azais from MSD. So I'm a colleague of Doug, and we work together quite a bit on health system policy. Just to complement and to ask a question to the panel and complement what Doug was saying, my company, MSD, is very much involved in a number of projects with health systems in order to address inefficiencies, especially along the patient pathway. We're doing and we have a long history also in some countries like the UK to provide IT services and things that just improve the functioning of the healthcare systems. And I'm mentioning the UK because whenever a pharmaceutical company is trying to do what we are doing right now in terms of improving efficiencies, there is obviously the question of trust, and that was mentioned by Professor. So there is a cultural difference across countries, even within Europe, on how they will engage with a private sector partner. And my question would be, how, do you see that there's a where might go the trend? Because Doug was saying he's coming from another, he was coming from other industries, and we've seen in other sectors how whole industries have become solution integrators. And so when you take this look at healthcare systems and you come from another background, you say, well, basically health authorities are health solution integrators, but they just don't realize it. And there's also the complexity that comes with it. But in a sense, I would strongly think that the future is a greater interaction and convergence, both in terms of methods but values as well, between the health authorities, the health system managers, and private sector solution providers.
Other questions? So I asked the panel if you want to answer to this first question, if you want to give a comment. You want?
Okay. Well, I think you raise a very relevant question. I think the first change, one of the biggest changes we have, is that we are moving from single pieces, let's say drug, pills, or device, to a system. And I know companies are working on that, and the expectation is that they're providing systems. And probably the payment system will be system and outcomes more than single pieces. There are some experiences on that, so I think that if we move this in that way, obviously the partnership should be well defined. So as far as I know, there are differences in the way different countries approach the interaction between public health services and industries. But once I think the movement of the system and the expectation and the tools available are services or integrated services, you have to define exactly which part of the system, what you have to do, and clarify that, making clear the different aims, the different goals, different interests, try to control the conflicting interests, and then to try to manage. This is an overview, is my personal opinion. I'm not expressing the opinion of my country, but I think that the trends are in this way, and as much as we integrate, or we ask for integration of systems in healthcare, as much as we need to put together not just the relation between national health system or regional system, one industry or one factory or one producer, but a system that can put together also different producers. So also in your board, I think, as far as I know, you are trying to cooperate or to provide a global approach to a problem.
Yes, I would like to add that I think in this perspective, transparency can be a very important element to allow this type of collaboration and integration. So would you like to give some other comments to these questions? Or other comments from the people here? No? So we can give just a couple of minutes each to give a last suggestion to the future panel and how we can make the difference in the future, what we could do better to have more impact in our work. So I think we could start from Professor Barros, if you want to have a couple of minutes.
Oh, thank you. One topic that might be really relevant, it's the way it's going to be organized, the process of expertise and of decision making. So that's just to put emphasis on what has been already discussed. That's the importance of co-production of all these decisions. That will increase, of course, or at least we expect that it will increase the transparency and it will make things more acceptable. So in the end, it will increase trust because people feel part of the solution. So they will be more interested in that. The other thing we need, it's to address the problem of society's medicalization. I think we are living in a maybe it's a transition from a world that we still have in our memory where drugs, devices, everything was so limited. And now we have this perspective of everything is possible. And, maybe the wrong side of this is mongering and these type of things. But I think we need to rethink the role of, or the way we see health in our society and understand and have a better understanding of the reasons why and the costs for society of medicalization.
Would you like to pass the microphone
Yeah.
to Frick? So if you want to get the floor.
Yes.
Quick comment?
Yeah, quick comment. I think, and I couldn't resist tweeting it as well, I think it's important for the European Commission to accept that they're policymakers. I heard several times now that the Commission would not be a policymaker. I think it is a policymaker. Like, if you're involved in selecting teams, if you decide to have an expert panel, if you have a role in the follow-up of the recommendations of the expert panel, you're part of the policymaker machinery. And I think accepting that that's the case will actually improve the impact of the opinions.
Okay. Well, I think two issues. The first one is probably this kind of activities, as well as the opinions, should be better known or shared around Europe. And at the moment, there are still a tool available for few experts passionate for public health or something like, but a minority, a small minority of that. So I think it's a pity. It's a great resources, is producing very good ideas, or at least is launching a debate that can be open to all our community. And this is, I think, one of the challenge. Any will be the topics, for any topics, any panel will be in the future. The second one, I think the investment on, I think the key point is human resources. Someone spoke about preparedness, but we have a great opportunity in the European Union, and that we have some agents like EUEMS, and we are regulating professionals, we are recognizing degrees, and we have to intervene a little bit in the pre-graduation area, in the post-graduation area, and then life professional long learning, because there are many of the issues we discussed, the recommendation, the plans by European Union, impact on that. If we don't act on healthcare forces, human resources, you are not able. And this is a guarantee also of equity or in the movement of the people, because professionals are moving around Europe. And if there are a little bit of common background, I think can be a great improvement for all the system, not just for a single country, but for all the countries.
Absolutely. Please, if you want to.
Thank you very much. Let me just build on the professor's remarks, because I think it's really, really critical. So when I look back at the original cover sheets of the first reports from 2016, they had the lovely white piece of paper and the blue logo of the commission, and then the title. And when I look at the most recent ones, there's color, more than blue and white on that. And I think that that's a recognition that how you communicate sometimes is as important as what you communicate. And when I look at this, and again to build on my predecessor's comments, I think how we disseminate and engage with Europeans on this is absolutely critical to this success going forward, because there's a great work here, but if it stays within the Brussels bubble or a Brussels capital bubbles, it's probably less good than if we are able to disseminate that. That probably means that we need to work with the executive summaries as opposed to the full reports, perhaps, or even executive summaries. But the content is there. The question is about the communication.
Yes. No, on this last point, I certainly agree that we could do much better in terms of communication with the Commission about the panel's opinions, and I wish I would be able to do that, and this is really something I will try to convince my bosses we should do. So if you want to let them know, you're welcome. But I feel I also need to react on Frick's point, and I'm happy to do that because to clarify, we can discuss whether what I said, we're not policymakers, was the right thing to do. What I wanted to say is that, we're not running a health systems here from Brussels. So my colleagues and I, we're not in charge of, like some of you are in this room or are close to those who are. So that's what makes a difference, I think. And of course, then we are part of policy shaping or policy making to the extent that, yes, we are connected. But this is then multi-level policy making. And it's in this multi-level world, which in the area of health still is sensitive and complicated. Maybe some of the member states colleagues in the room would be happy to comment, where the way we coordinate, the way we articulate, where we all know, or they all know, how much they have in common, but at the same time, they're not always convinced that working together is going to be the best outcome. Personally, we are convinced that it would be the best outcome, but they're not always. And there are trade-offs, and there are different ways, and there are different reasons. So it's what I think we could, coming back to the panel, what I would like to say then is that let's see whether with the panel opinions we can actually support that process of multi-level cooperation, and so between the EU level and the national level, but also across the national levels together.
So thank you, Sylvain, very much, and thank you to you all for participating at this third session, and thanks to all the panelists that help us in discussing the topic of the session. I invite you to get some coffee and to be back for the last session for 3:45. Thank you.